So hello guys, welcome back to my channel again. Let's study leukoplakia as I said in the last video. What I missed in the last video was the classification of the epithelial neoplasms of the oral cavity. So the epithelial neoplasms of the oral cavity are classified as benign, pre-malignant and malignant. Okay, so in benign we have squamous papilloma, squamous acanthoma and keratoacanthoma. In pre-malignant we have dysplasia, leukoedema, oral lichen placus, erythroplakia, staging of oral precancerous lesion, oral submucous fibrosis and palatal erythema. Whereas in malignant we have basal cell carcinoma, squamous cell carcinoma, verrucous carcinoma and malignant melanoma. From here today we will be studying from the staging of precancerous lesions. So in precancerous lesions we studied in the last video that we had two lesions which are erythroplakia and leukoplakia. Okay, so there were two lesions, erythroplakia and leukoplakia, from which today we will be studying leukoplakia. So the past questions which I myself found on oral hairy leukoplakia, this came, and another is define oral leukoplakia, write the different forms of leukoplakia. So these were the questions which were asked lately. So if you know there are other questions, please comment down below which I missed on leukoplakia. So let's start with the topic leukoplakia. So leukoplakia, leuko means white, leukoplakia, so leuko means white, okay, and plakia means patch, so it's a white patch. Okay, so leukoplakia means a white patch, and the WHO definition of it is, as asked, is a white patch. Okay, so it's a white patch or plaque that cannot be characterized clinically or pathologically as any other disease also, and which cannot be scraped off. Okay, as you can see, leukoplakia is unscrapable white patch, diagnosis of exclusion. So we have to do diagnosis of exclusion, that it is not related to any other condition and it is a white patch and it is unscrapable. Okay, so let's go back to here. So as you can see, here is shown, so this is leukoplakia, and it is only used as clinical diagnosis of exclusion, not or never microscopic or histological diagnosis. So never. Okay, so it is never used as a microscopic or histopathological diagnosis. So let's move on to the clinical features. It is a most common oral precancer, represents 85% of such lesions, affects as many as 3% of white adults, strong male predilection 70%, location anywhere buccal mucosa and commissures are mostly involved, whereas the appearance vary from small, well localized, irregular patches to diffuse lesions involving considerable area of oral mucosa. Multiple patches may vary from non-palpable, faintly translucent white area to thick fissured papillomatous lesions. So this is thick, okay. Okay, so surface is finely wrinkled, cracked, mud appearance, rough on palpation. So it is basically rough, can be diffused to localized. Have this mean ebbing tight type. So it is seen in leukoplakia that occurs in floor of the mouth. These sublingual keratosis are bilateral and possess a parallel corrugated wrinkled surface texture described as ebbing tide, since they appear similar to the undulations left on the sand by ebbing tide. So this is ebbing tide, and like it has left the indurations in the sand over here. Same does the leukoplakia in the floor of the mouth. As you can see, it is like a ebbing tide like appearance, like this. So this is why it is called a ebbing tide type. Okay, so this we have already discussed. Now let's move on to the forms of leukoplakia. Leukoplakia have two forms. It can either be homogeneous or it can be non-homogeneous. Okay, so either it can be homogeneous or it can be non-homogeneous. So smooth, furrowed, ulcerated are homogeneous, and non-homogeneous are nodulous speckled. So so this is about homogeneous. So this is a homogeneous leukoplakia. As you can see, this is a predominant white lesion of uniform, flat and thin appearance. So it is uniform, it is flat in the mucosa, and it has a very thin appearance. Okay, so that may exhibit shallow cracks, and that has a smooth, wrinkled or corrugated surface with a consistent texture throughout. Okay, so it has a consistent texture, it is smooth, it is thin, may allow cracks over here, like you can see, it can may have cracks, and has smooth, wrinkled or corrugated surface. So it has smooth, wrinkle. So you can see this is what it means by corrugated or wrinkled surface, and it is usually asymptomatic. Okay, so here the risk of malignant transformation is very low in this, since it is asymptomatic and it is like superficial, and so it has low risk of malignant transformation. So this is what? This is a homogeneous leukoplakia, whereas non-homogeneous leukoplakia is a nodulospeckled. Okay, so a predominant white or white and red lesion, erythro leukoplakia, that may be either irregularly flat, nodular, which is speckled leukoplakia, or exophytic or verrucous leukoplakia can be symptomatic. So this is a little bit of symptomatic. So malignant, so it is symptomatic, and malignant transformation, risk of malignant transformation is also high in this. So a prominent white or white and reds, this is completely white. Okay, so this part is completely white. I mean, homogeneous form of leukoplakia are completely white, as we saw, but this leukoplakia, this is red, white, nodular speckles. This is not completely flat, so this is somewhere it is nodular, and somewhere it can be cauliflower like, which is verrucous or exophytic. Okay, so these are the type of non-homogeneous leukoplakia. Okay, so as you can see here, verrucous means cauliflower like. As we see cauliflower, you can see the cauliflower like appearance over here. Can you see this? Okay, and then these are the speckled ones. As you can see, there are like dots and dots of leukoplakia, and it's so nodular and exophytic. This is the common type of leukoplakia. Okay, pathophysiology and histopathology. Simply, this is not asked most often, but let's read it out. Pathophysiology: tissue cell is exposed to any type of carcinogen, it probably tries to adapt to it. Okay, so when tissue cell, a cell, okay, let's do it here. A cell is exposed to certain carcinogen. Okay, carcinogen is exposed to this cell. This is a cell. Then it probably tries to adapt to it. So it tries to adapt, right? Tries to adapt. So when it tries to adapt, an increase in cell proliferation, hyperplasia, so that would cause hyperplasia. When the irritant persists further, the epithelium shows features of cellular degeneration, a well-characterized feature of adaptation. It will show hyperplasia, then it will show cellular degeneration. Okay, it will show cellular degeneration. Then second thing it will show is atrophy. When the stage of adaptation and reversible cell damage ends, the cell gradually reaches a stage of irreversible cell damage, manifesting as either apoptosis or malignant transformation. Apoptosis or malignant transformation. So as I said in the earlier video too, if you haven't watched, please go and watch. So when the cell is exposed to certain carcinogen, it tries to adapt to it. So in the process of adaptation, it undergoes hyperplasia, where it can undergo cellular degeneration. Okay, and if it undergoes, if the cell damage, reversible cell damage ends and it becomes irreversible, then it undergoes atrophy, which can be apoptosis and malignant transformation. Okay, so this was all about pathophysiology too. Now let's talk about the histopathology. So leukoplakia is purely a clinical terminology, and histopathologically it is reported as epithelial dysplasia. Okay, so WHO in 2005 proposed 5 grades of epithelial dysplasia based on architectural disturbances and cytologic atypia. So first one is squamous hyperplasia, mild dysplasia, moderate dysplasia, severe dysplasia, and carcinoma in situ, which has poor prognosis. So this is a benign lesion, this has better prognosis, and then there is moderate dysplasia, severe dysplasia, and carcinoma in situ. So these are the 5 grades of epithelial dysplasia. Now there are surface changes, which are keratosis, hyperkeratinization. There are epithelial changes, vascular degeneration, stratum spinosum or germinatum, acanthosis, stratum spinosum, basal cell hyperplasia, intraepithelial edema. Then we have dysplastic changes, and then we have connective tissue changes. Okay, so these are the changes of that occurs in the histopathology of the leukoplakia. As you can see here, the hyperkeratosis can be seen. Okay, so here you can see the hyperkeratosis thing. Yeah, so yeah. Talking about pre-leukoplakia, so there is also a condition called pre-leukoplakia. Okay, so it is defined as a low grade or very mild reaction of the oral mucosa, appearing as gray or grayish white but never completely white area, with a slightly lobular pattern and with indistinct borders blending into the adjacent normal mucosa. So you can see here, very mild reaction of the oral mucosa. You can see here, this is very mild. So it has slightly lobular pattern and the borders are indistinct. As you can see, I underlined it, but you can see the borders, they are not very distinct borders like in the previous lesions. So this is pre-leukoplakia. Okay, so this is gray to whitish. Okay, and it has low grade and very mild reaction of the oral mucosa. So the borders are blending into the adjacent mucosa, as you can see here. The borders, it is totally blended with the normal mucosa. So this is pre-leukoplakia. This is also a condition, can be sometimes asked in viva. Not so important for the theory exam if you are a TU student. So etiologies are simple. It can be tobacco smoking, alcohol, candida albicans, sanguinaria, ultraviolet radiation, microorganisms, oral hairy leukoplakia. So this is asked as a short note in exam. So I have made a pretty good short note here. So let's discuss. So definition is oral hairy leukoplakia is a white, non-removable corrugated lesion of the oral mucosa, most commonly on the lateral border of the tongue, associated with Epstein-Barr infection and seen mainly in immunocompromised patients such as those with HIV/AIDS. Right? Corrugated means here hairy, so it is corrugated, so it is also called hairy leukoplakia. Most commonly on the side is lateral border of the tongue, most commonly. Okay, so then it is associated with Epstein-Barr virus. Okay, and mainly in immunocompromised patients such as HIV/AIDS. Okay, so that is it. Now let's move on to the clinical features. Okay, so clinical features, side it is seen in bilateral lateral borders of the tongue, other sides buccal mucosa, floor of mouth, soft palate, pharynx मा पनि देखिन सक्छ. मेनली चाहिँ bilateral borders of the tongue मा देखिन्छ. कस्तो देखिन्छ त भन्दाखेरि white vertical streaks, shaggy corrugated surface देखिन्छ भनेपछि चाहिँ युजुअली चाहिँ पेनलेस हुन्छ अनि असिम्टोमेटिक हुन्छ है. हिस्टोप्याथोलोजीको कुरा गर्नुपर्दा चाहिँ एपिथेलियल हाइपरप्लेजिया हुन्छ. यसमा चाहिँ एकान्थोसिस हुन्छ, हाइपरकेराटोसिस हुन्छ, बलुन सेल्सहरू देख्छ इन अपर स्पाइनस लेयर, न्युक्लियर बीडिङ हुन्छ, क्रोमेटिन अलोङ न्युक्लियर मेम्ब्रेन. सो न्युक्लियर मेम्ब्रेनमा चाहिँ क्रोमेटिन छ भने चाहिँ त्यसलाई हामीले के भन्छौँ, न्युक्लियर बीडिङ भन्छौँ. सो एबिबी पार्टिकल्स, एप्स्टिन-बार भाइरसको पार्टिकल्सहरू देखिन्छ र क्यान्डिडल हाइफी पनि देखाउन सक्छ है. सो दिस इज all about the histopathology of oral hairy leukoplakia. Now let's move on to the management. Usually there is no treatment and needed if asymptomatic. So if it is symptomatic, then you can use antifungals, antivirals, clotrimazole, ketoconazole, encyclovir can be used. So that was all about leukoplakia, which is not